Okay, here's a projector.
While he's playing with that, let's just see if we can get this thing to run.
Plug it in there.
He's got a cord. I thought I saw a cord, maybe not.
Thank you, Mark.
So you got basically in a computer, but I guess you don't.
Because I've used this in these situations, so I know the computer well. There's two of them. Let's see. Control, that's it. That looks like the one. It says, they both, oh yeah, well, let's see. What do we got here? You got, yeah, it's this one. Short, yeah. It looks like it just recognized it.
Oh, did you just turn it? I'm sorry. I just turned it off high.
Did you?
Power.
Power.
Yeah, well, I clicked it and realized it had gone the other way.
I don't think it's on. Power should be green there.
Okay.
It's on.
I'll warm up.
I've got a cord. You need a cord to go?
Oh, here we go. See, this is, it's, I got my thing. It's recognized it. I've recognized it.
Here, stick here until we get into this thing. Since you're not. Oh, it's got an eraser on it there.
I probably should have said something.
It's
Okay,
there.
There's there.
Okay.
I know what the eraser's for.
Yeah.
Just to make it go higher.
Okay, but I'm going to have to have somebody click it.
Hey, I can do that.
It just, I'm sorry. Just use, just go.
I've got a clicker if you want.
Yeah?
You got a USB thing for it?
Yeah, if you've got another port.
Yeah, I do.
In the interest of time, I think we'll begin. We've had a little bit of media issue that looks like we're getting.
Just turn it on right there, and then that advances it, and there's a laser pointer with the red.
Let's see what happens.
Science and Health, and I'd like to welcome you all to this symposium speech, and we're very, very fortunate and lucky today to have with us
May not have
Dr.
the-
Greg Craner. Dr. Greg Craner is the medical director
Oh, wait a
of
minute.
the Central
Here's
Utah
why.
Clinic, where he has been for the past many years. I just
And
got
that red's a laser pointer
one of
right
our
there.
faculty members is out with neck surgery. He just
Learning it.
posted me a note that said he had been having a year's worth of gastrointestinal troubles and no one could fix him, and he went finally on a Saturday to the ER, and Dr. Craner came over and immediately diagnosed him, and within hours was properly diagnosed and taken care of. But I wanted to say a few things about Greg, and I'm not going to take much time because we're starting just a tad late. Dr. Craner is the head of our advisory council in the College of Science and Health, and was very instrumental in recent months in working towards the acquisition of the funding for the new science building. And we actually, under unbelievable odds, were able to have the new science building funded back 2 weeks ago, 10 days ago. So groundbreaking for the new UVU science building will be probably the 1st of June. That's really huge, and I personally want to thank Dr. Craner for his heavy involvement in working towards that with the physicians in the valley, and at the last minute being up on Capitol Hill to lobby the folks in the legislature. So thank you, Dr. Craner. And I'm going to skip the rest of the introduction because of the time constraints. So
Good.
you're lucky to be here today. I've heard Dr. Craner speak on evidence-based medicine, and he's got a great talk.
Thank you, Sam. Okay, is the mic working? Sounds like it is. All right, well, I appreciate being able to do this. And actually, it's very exciting to be associated with the school. I've been more excited the longer it goes on, but I appreciate being able to give this talk. We did this several years ago, but since that time, things have changed. And if you've listened closely, President Obama, both on the campaign trail and subsequent as he's working with healthcare reform, has frequently used the phrase evidence-based medicine. And evidence-based medicine has really come to the forefront as we start talking about healthcare reform, health controls, quality of medicine. And you're going to hear more and more about it. So it's a good idea to kind of know what it is that we're actually talking about. What we're going to do, though, we're going to start with a little bit of history so we can kind of see how we got to where we are and how we got to learn to think the way that we do when we think about medicine. So we're going to start with some history, which I think is really exciting. Then we're going to talk about what evidence-based medicine really is. And then we'll talk about some of the pitfalls of evidence-based medicine, those things that it does not do well. And then we're going to talk about how it relates to healthcare costs and reform. And then we're going to finish by giving an example of where evidence-based medicine collides with public opinion and what happens when that occurs. And something that some of you may remember. We're actually going to start with George Washington. George Washington was obviously the most powerful person of his time in the United States. He finally got through being general, he got through being president, and he finally got to do what he really wanted to do. He wanted to be a farmer at Mount Vernon. So he finally retires to Mount Vernon. It's winter time, he's out on his horse inspecting his crops, and he gets bronchitis or pneumonia. It's not clear, probably just bronchitis. Comes back, and of course, as the most important person in the country, he gets the best treatment. Well, the best treatment consisted of the physicians coming and bleeding him, phlebotomy. They bled half of his blood volume from him in an effort to cure him, half of his blood volume. And he probably died from the bleeding and not from the bronchitis. So the question is always sort of in my mind as I went along is, how could these doctors have been so dumb? I mean, it seems just a priori that was not a good thing to do. How did they come to the conclusion? Because these fellows were actually as smart as any of us. These were bright guys, the brightest of their time. And yet they came to that. So you think about that. We think about how is it that we know what works and what doesn't work. We take a look first at the pitfalls that led them to that particular conclusion. There was a lot of bleeding going on. Benjamin Rush, who was one of the signers of the Declaration of Independence, was a big believer in phlebotomies. You could phlebotomize from a number of places, some of which or not be very pleasant. But the way they got into this is that the Greek philosophers had decided that all elements are made up of four basic elements: air, fire, water, and earth. And then Aristotle put that together in the human body and had the four humors in the human body. And all disease and everything that's bad is either because these are out of line or those are out of line. And so it's imbalance that causes disease. Too much blood, too much phlegm, we get the word phlegmatic from that. Yellow bile, black bile, actually there's no such thing as black bile. Black bile is actually blood that you're vomiting up when you have ulcers. But disease now related very well to how the world was put together, an imbalance of these things. Benjamin Rush said, well, it's obvious that fevers are caused by too much blood because when you're feverish, you get flushed and your skin gets red. So you've got too much blood, so we get rid of the blood, things will get better. So they had this philosophic basis for bloodletting. It started with Aristotle. It was then formalized by Galen, a Greek physician in the 2nd century. And from the 2nd century to the 16th century, learning medicine was only reading Galen. That's all you did. You didn't look at people, you didn't do autopsy, you didn't do physiology, you didn't do anything except read Galen and think about these philosophical underpinnings of what causes disease. So what we have for these doctors is they had three things that told them that bleeding was right. They had their philosophic basis that we just talked about. They had the authority of 2,000 years of people saying that that's what you should do, Galen. And they had empiric evidence. How many people had the flu and got better? Yeah, well, a lot of us did. We all got sick and got better. Or you haven't sometime in your life. Well, if you had been phlebotomized during that time, you would have accredited your recovery to the phlebotomy. So what would happen is people would get sick, they'd be phlebotomized, and they'd get well. So we had empiric evidence that phlebotomy worked. So we had philosophic basis, we had authority, and we had empiric evidence. And those are the things that led these really smart physicians down the road to phlebotomizing half of George Washington's blood volume in order to cure him. These are traps that we still fall into, and we're going to be coming back to that. So the question then comes out, how do we get from this, which leads us to the inappropriate conclusions, to coming to the proper conclusions? What are those things that are necessary to decide what really works? Well, we had some interesting people that helped us along the line. This is Pierre Louis. He was a Frenchman, and he was looking at the people who were bled and looking at the same thing. He said, you know what we should do? We should just count and see what happens. So he took 77 people that had pneumonia, and he counted those that had phlebotomy early and those who had phlebotomy later, and found out that the people who had less phlebotomy later did better than the others. So we just count, and he finds out if you just count it, it turns out phlebotomy doesn't seem to work. And then he came up with this statement, which today looks like, well, duh. He says if you take two groups of people and you treat one way and you don't treat the other group, and one group gets well and the other doesn't, you can kind of know if the treatment works. This was a brilliant idea. Nobody was doing this sort of thing. There were a few people, Francis Bacon, for instance, who was kind of talking about maybe we should do empiric, look at experimental things, but people still were teaching out of philosophy. This was a brand new idea, that of actually measuring. John Grout also thought that maybe what we should do is just kind of measure what's going on in the world so we can see what's really happening. So he simply took the population of London and looked at what was killing people and put together the first list of what actually killed people. And this was the basis of statistics. Statistics, the word statistics comes from the word state, which really means find out what's going on in your state, in your country. And so this was his list. I thought it was interesting. This is what people died of in London in 1632. And there's some really interesting things here. We have one, I'm going to use my UV pointer. We have one poor guy here who was scared to death, affrighted. But you know, we think it's better to be alive now than it was then. But it turns out that if you look at made away themselves, which means suicide, you only had 15. We seem to be wanting to exit this life a lot more than they did. We have a lot more problems with suicide than 15. But here's the one I find most interesting. Teeth. 470 people died of abscessed teeth in London. Well, he looks at this sort of thing, puts it together in life charts, and starts to learn things about looking at how things really work. There are a lot of other really cool stories. The story of John Snow, there was a cholera epidemic in a town in France, and he looked at populations and carried them around, who got sick and where they were, and got it down to a pump in the center of the city where people were getting their water. And the city fathers wouldn't close it down, so he went out at night and took the handle off the pump and got rid of the cholera. But these are all just inklings of getting to where we are. One of the problems we have with when we talk about biological systems is biological systems are messy. They do not apply themselves to just thinking about it like, for instance, physics does. Physics is not a messy system. And one of our best examples about this is Leo Szilard. Leo Szilard was a brilliant nuclear physicist, and he was working at the time in the 30s when exciting things were happening about finding out how the atom was put together and how it works. And they just discovered fission and the neutron. And he remembers, he says, I was standing at a stoplight in London one day, and I was just thinking, what would happen if more than one neutron came out? And he came up with the chain reaction. Just standing on the street corner, waiting for a stoplight, came up with the idea of a chain reaction, which he later patented. Later on, he went to the Manhattan Project, was involved with that, but later on he got interested in biology. And he went and worked for the Salk Institute. And he made the comment, he says, ever since I got involved with biology, I could no longer enjoy my bath. Because what he liked to do is he liked to lay in his bath and think about physics. And he'd think about these things, he says, but when I lay in my bath and think about biology, I have to get out of the bath and go find out some fact about whether that is really true. I can no longer just think it through with biology. So becoming a biologist ruined his bath. So biology is not physics. I'm not going to make any comment about which is the most exciting, but biology is not physics. You have to be very careful, of course, about authority. It turns out authority is a very poor way of knowing what is right and what is not right. I've been doing medicine now for 40 years, and I can't tell you how many things that I was told in medical school turned out not to be true. And we have to be, we have to be extremely careful about empiric evidence. As human beings, we are really prone to believe what we see more than we should. And we develop these arguments that really are not right. One of them is post hoc ergo propter hoc. What that says is, because it came before, it was the cause of. So if something happens and we say, I got sick last night, so it must have been because I ate at McDonald's. Well, maybe and maybe not. It was the cause of that. This is where many superstitions come about. I was talking to my brother-in-law about one of these, about the rain dance. How many people really think that dancing makes it rain? Well, then how come people got to believe that? Well, they believe it because one day someone danced and the next day it rained. That's post hoc ergo propter hoc. The other one is cum hoc ergo propter hoc. That means because it occurs at the same time, they must be related. Because they occur at the same time, they must be related. Here, for instance, is the average temperature of the Earth and the number of pirates. So obviously, the answer to global warming will be, we need to have more pirates. Because they occur at the same time does not mean that they're related. So one of the main things that you learn when you take Statistics 101 is association is not causation. And we have to be able to sort those things out. We have to be able to sort out is these two things just happening because they're just kind of happening at the same time, or is there a true causal relationship? And that is the basis of evidence-based medicine. The basis of evidence-based medicine is this really caused by this? Does this medication really do this? Does this disease really do this? Does this treatment really do this? So does this cause really occur? And that is the basis of what we try to find out with evidence-based medicine. Now, it was a long time getting us to this point. We've gone through the philosophic part, but then it was a long time even getting to the scientific basis. In 1910, William Flexner was asked by the AMA to look at the medical schools in the United States. And at that time, there were 150 medical schools in the United States. Many of them were owned by the faculty. They didn't have any clinical experience. They just had a couple of books. They had no lab. He went and looked at all 150 schools, and his final conclusion is 120 needed to be closed immediately. That left 30. 28 needed serious fixing. There were only 2 medical schools in the United States that were based at any scientific basis, the main one being Johns Hopkins. And from that kernel, actually, of the Johns Hopkins, we developed our current scientifically based medical school, medical education. It was, and that's just 100 years ago. So that was a big step. We need to answer the 2 questions. What can we know and how do we know it? So how do we make decisions about what works? We already talked about the problems with authority. Then there's case reports. Case reports is sort of like the simplest way to do that. I saw this person, he had this, and this is what happened to it. But that doesn't particularly help us with anything. Those are anecdotal. Those are related to some of those other things we've done. Personal experience. We have a tendency of human beings to give our personal experience too much credit. There's a computer program out now called the Apache program. And what it does, if somebody comes into the intensive care unit and they're very sick, you put the parameters and everything in the Apache program. And it tells them what their chances are of recovery, what the best kind of treatment is for this, and what you should be doing. The computer tells you that. And everybody says, well, you don't want to do that. You want to go by our personal experience. Well, it turns out that it works better than the doctor. And the reason it works better from the doctor is because we are all overly influenced by our last bad experience. The computer is not. So if we had a patient like that and they had a bad experience with it, that influences heavily what we're going to do, even though it has probably nothing to do with what we should be doing. So the computer is better because it isn't influenced by our last bad experience like humans are. Then there's scientific studies. We're going to look at some of those because there's some that are good and some that aren't. Actually, I had an example here, so we might as well talk about that. When we start looking at studies, some of the things we're going to talk about is how do you know if that study's any good? Because there's a plethora of studies out there. And one of the examples I remember reading, this is about 10 years ago, they're trying to decide whether or not to use HRT as hormone replacement therapy. Whether or not women, when they became menopausal, should be placed on replacement hormones. It was a big question. So they looked, very easily, like the first guy, they looked at the women on hormone replacement and they looked at the women not on hormone replacement. And they found that the women on hormone replacement had a death rate 30% lower than those who were not on hormone replacement. Seemed to be pretty clear. So it looked like it was a benefit to be on hormone replacement because it cut your chance of dying from all causes by 30%. Well, it turns out that was not true because those people were self-selected. So if you're involved with your health, if you exercise and you went to your doctor and you did a diet and you got into stuff, then you were probably in this other group. If you just didn't care, you didn't go to the doctor, you ate whatever you wanted to, you probably never got your replacement. So they were not comparable groups. Some of them was called selection bias. So when you look at studies, there's a whole bunch of stuff we're going to look at to see if that really means anything. And that's really what gets us to evidence-based medicine. Here's a definition of evidence-based medicine. It's the conscientious and explicit and judicious use of current best evidence in making decisions about the care of the individual patient. And it takes a lot of work. It takes a lot of work to use evidence-based medicine because you have to actually go and look at the evidence that you're using. And we've been to help with this. Archie Cochran decided that he was going to take this to the next level and develop now what is called the Cochrane Institute. But basically what he does is he will take the studies in a particular question and he'll look at the quality of the study, combine those studies in a mathematical basis, and decide whether or not that study actually supports the conclusion. And some of the things that they look at is whether or not the study is the quality of the study. The best study is a randomized controlled study. Randomization to entry, blinded, controlled, placebo-controlled study is the best type of study. Other studies are designed but not randomized. That's like the one we talked about with the hormone replacement therapy. Cohort studies, that means that we really can't do a randomized study, so we know that for the past 20 years we've treated people like this, so we're going to look at what we did, then we're going to change the treatment and look for the next 10, 20 years, then we'll compare those two cohorts and see if there's been a difference. Multiple time series, and then level 3, opinions of respective authorities. These are decreasing qualities of whatever the evidence is that you're trying to do. So then he puts that all together and says, okay, now we have this recommendation, for instance, we have this recommendation about hormone replacement therapy. And we're going to say you should not do it. And what kind of level do we have? Is this a level A? Do we have good scientific evidence? Is it level B? Is it fair? C? Is it fair but it isn't enough to make a big difference? Or is it a level I where you can't support it at all scientifically, it's just somebody's opinion? And so then they'll put this out and say, this is how strongly we know that this is really going to work. The criteria for some of the stuff that we want to do is if you want to have a good study, a good thing, you have to have sufficient power, you have to have enough people, it has to be randomized properly, you have to make sure that you're selecting the subjects that are appropriate to what you're doing, and it needs to be placebo controlled, because we all know there are placebo, and when they talk about placebo control, they talk about how people will get better on placebos. That you'll give somebody a sugar pill and 20 or 30% of the time they'll feel better. I think my best example, the one I find most fun about placebo control is fluoridation. When I was actually in high school, one of my first things I wrote about was the story of fluoridation. And there was one city that decided they wanted to put in fluoride. So they told the public they're going to put in fluoride on July 1st. Well, the machinery didn't get there. So they didn't get the fluoride in time. But July 1st, they started getting letters from people about how it's changing their pots and pans, how they were sick, they weren't sleeping well, they're having headaches, but they hadn't done it yet. So placebo stuff works in both conditions. It's placebo. There is a major question though about whether you should use placebos. We used to have, when I was in medical school, we'd give people placebos. We gave them Obepas. Anyway, we spelled placebo backwards and wrote it on the prescription pad, and they'd give them some sugar pills. There's an herbal product out that is supposed to help prostate health, supposed to help prostates, prostate flow. Well, prostate flow is something that you can quantitate. So they did a double-blind placebo-controlled study, and they found out that it did not change the urine flow with prostate, but half the people thought it did. So the question was, this is something really you're just kind of bothered with and you're thinking about. Maybe it's, if you feel better, it's okay to do it. It needs to be transparent. You need to make sure everybody knows what you're doing. It needs to be reproducible. It needs to be quantifiable. And we'll look at some of that stuff. I'm not going to go through these. These are the criteria that were developed when the Surgeon General was trying to decide whether or not smoking caused cancer. And they put together those things that they thought helped us decide whether a cause was appropriate. And these are the sorts of things that they looked at when the Surgeon General finally came out and says, yes, smoking causes cancer. It's interesting. When I was in medical school, at the time this whole thing was going on, my professor of ear, nose, and throat, who wrote one of the textbooks, would stand up and pace back and forth smoking during his lecture. And he was absolutely adamant that smoking did not cause cancer. I mean, there was my authority, the guy who wrote the book. He actually, unfortunately, developed head and neck cancer. But he was wrong. I mean, the authority teaching it. And so they had to go through with this. We get a number of interesting little things out of evidence-based medicine. We have a thing called the number needed to treat. How many people do you need to treat with this drug before one of them gets better? And if you have to treat 100 people with a drug before one gets better, it's not a very good drug. Most of the time it comes in like 5, 6, 7, 8 people you have to treat. And if one person gets better, we say that's a pretty good drug. We also have the number needed to harm. How many people are you going to give this drug to before you hurt somebody? You want that number to obviously to be quite low. And then an interesting interesting form that's come up is called meta-analysis. One of the problems with many of the studies is they're too small. They're not powered right. You got this little study here, a little study here, a little study here. What meta-analysis does is it takes all of that data from all of those studies, weights them by how good the study was, puts them all together in one study, and then allows you to make some conclusions. But there are problems, and there are some significant problems with evidence-based medicine. One of the problems is getting people to believe it. It's very hard to get rid of old ideas. When Luis did his study on bleeding, it was 100 years before people started to believe that. When they had studies that had to do with washing your hands before you partook in deliveries, was a long time before people started to believe that. It's hard to get people to convince things. According to medical science, we can't cure the common cold, but neither can medical science. Which actually brings up this interesting one. About 10 or 12 years ago, there was an article in the New England Journal that echinacea helped reduce the symptoms of the common cold. One study. Subsequently, now you can go buy echinacea everywhere. Right? Well, now this study comes out. It's larger. It's better designed. Definitive answer, 2005, 5 years ago. Final conclusion was echinacea does nothing for the symptoms for the common cold. Remember, one of the things about a good study is it has to be reproducible. Well, it's not reproducible. We've had now multiple studies that show it doesn't work. But you go to the drugstore, and you're still going to find it on the shelf. And you're still going to find people that take it and swear by it. It really made me better. The trap we get into sometimes is the story that someone will have a viral illness which is going to last 10 days. So they go to their doctor and they browbeat their doctor and they say, I want an antibiotic, I want an antibiotic, I want an antibiotic. So you give them an antibiotic, it doesn't do anything because they're still sick. So they come back 5 days later and say, I want a stronger antibiotic, I want a stronger antibiotic. So the doctor gives them another antibiotic. And then, of course, the 10 days are up and they get better. And so now a year goes by, they get another viral illness, they come back to the doctor and say, I want that second antibiotic because that's the one that made me better. And that's the kind of traps that we get into, and it's very hard to overcome. So anyway, despite that, it's hard to get believers. Now, I thought this was an interesting statement, that a wealth of information awaits discovery of the psychology of personal beliefs, of irrational proposals, and the study of erroneous thinking. For instance here, this is my favorite headline ever. I'm going to let you just think about this for a minute. And then Utah students, not big on writing. Test shows 1/5 of state's 8th graders perform below the national average. Yeah, okay, did everybody get this? What are we, Lake Wobegon? Everybody has to be above average? This is actually very good if only 1/5 of your students are below average. It's not bad. Obviously, this journalist is suffering from not illiteracy, but innumeracy. But people don't know. I mean, the amount of understanding of how to handle statistical information by the general public is abysmal, to say the least. It is, and that's why you get polls and all this stuff, and people can do whatever they want because they just don't know. But that's one of my favorite headlines. Also, some things cannot be placebo controlled. There are certain things you just don't want to do a placebo controlled study on. Here's one of them. Can't convince anybody to do placebo controlled studies on. But there's some practical aspects. There was an article in Atlantic Monthly a couple of months ago that pointed out there have been no placebo controlled studies of the flu vaccine. We really have never done a placebo controlled study of the flu vaccine because nobody is willing to take the placebo because we're all so much believers that it's going to work. So we have to do longitudinal studies. And one of the longitudinal studies, for instance, showed that if you have a flu vaccine, your chances in the next 6 months of dying from all causes are cut in half. Well, obviously the flu vaccine doesn't do that. It's because it's selection of the people who get flu vaccines. But metastatic breast cancer. For a while, metastatic breast cancer was going to be treated as a last-ditch effort with total body radiation and bone marrow transplantation. And the insurance companies didn't want to do that because it was extremely expensive. But eventually, public opinion, they finally forced them, they got them to do it. Then finally somebody did a controlled study. Nobody was really willing to do that because they thought it was going to be unethical because you're withholding treatment from somebody and they're going to die. Well, it turned out when they finally did the study, it didn't work. It didn't work. People just thought it should work. This is this is an infamous study where it shows that you don't want to go over the line. In the Tuskegee study, they had a number of black men who had syphilis, and they wanted to see what the natural course of syphilis was. Well, about the time they started the study, penicillin comes out and shows it to be very effective treatment for syphilis. Well, they wanted a control group, so they used these guys without their knowledge as a control group and didn't treat them as a control group. This is one of the studies that has led to the development of the IRB, the Institutional Review Board, so we don't do this kind of stuff anymore. So there are some problems getting evidence-based medicine studies done. You need to make sure that you're doing it properly. Another problem with it is that one of the things we like to do about evidence-based medicine, when you're doing a good study, you have one variable. You control everything else and you just look at one variable. Unfortunately, people don't come into your office with one variable. They come in with 5 diseases, 6 medications, 4 doctors, and a family person who's telling them they don't need to take the medication anyway. All that stuff has to be put together. So it's difficult sometimes to translate what's in the study into what is really there in real life. 20% of Medicare beneficiaries have 5 or more diseases. They're taking 5 or more medications. You have drug-drug interactions. All these things now is where you start getting into remember on the definition, it said the judicious use of evidence. This is where you get into the art of judicious use of evidence. By combining all those things that you know and trying to put them together into this one messy biological person who's there sitting in front of you. You got social effects. You say, yeah, this is the best drug for you, but it costs $100 a day. Can you afford that? Then you have to make some other decision. One of the other problems with evidence-based medicine is it's easy for abuse. It's very easy to be abused by people who have other agendas, particularly financial agendas, to withhold care, to direct care in some direction that may not be appropriate for the specific person you're seeing, but they use the studies to control what you're doing. Refusal of treatment, making payments on whether or not you're meeting certain guidelines. There was a pay for performance. This is a new thing where you're, instead of being paid to do something, you're paid for the results of what you do, which sounds like a great idea, and it usually is. But they had one group together where they decided they were going to pay. When you treat diabetes, you're trying to control a thing called the A1C. That's a long-term glycogenated hemoglobin. But the lower you get it, the better the control of the diabetes. So people were being paid on how low they lowered the A1C. Well, it turns out that then when they looked at other things like dying or having heart attacks, having strokes, those people who had them forced really low were dying more often. So now the physicians are actually being paid to drive down the A1C when in fact it was causing more deaths in their patients. So all of this stuff has to be taken into consideration. Well, how do we do as physicians? This is from about 10 years ago, but they went out and looked at the decisions individual physicians were making as their patients were sitting in there. And they found that about 4% were actually based on strong, good, grade A evidence. About half of it was kind of a mishmash. You took some of the evidence, you took some of your experience, some of the stuff you've been taught, put it all together. And half of it was kind of like, I think it's a good idea. It was based on personal opinion. So even the medical profession has a hard time getting to that, some of it because of some of these difficulties that we've talked about. But the important thing about evidence-based medicine now coming is it's going to play an increasing role in the delivery of healthcare under any type of healthcare reform. And it's going to be used by the governmental agencies, by insurance companies, in order to direct and decide what to do about healthcare. And we're going to look at a couple of things. For instance, one would expect that the more you spend on medicine, the better medicine you get. And so the Dartmouth University did a study where they took each one of the individual states in the union and they looked at how good the healthcare was and how much it cost, expecting to find that those states that spent more on healthcare had better health. So this is the, see, there is no relation. It's all over the board. So it doesn't seem to make very much difference. Down here, this is the worst state, the states down here. See, this is least affordable, so down towards the bottom is costing you more. This is the worst health, so you don't want to be here. You want to be this state right up here, which happens to be Utah. But there is no reason. So we look at this and say, what is it then that puts people over here? Well, it turns out, as a group, globally, that those people that are over here in the best health care tend to use more evidence-based medicine. For instance, in Utah, IHC has put together various practice guidelines. They have one for community-acquired pneumonia. It talks about when you should be hospitalized, what medications, what antibiotic you should use, how you should be treated, all based upon good evidence-based studies. By using those guidelines, it's decreased hospitalizations for pneumonias, it's decreased morbidities, and it's worked well. So these people in this part over here tend to use more evidence-based medicine. Now for the expense part though, these people that are more expensive, these are the bottom part, they tend to add stuff to the evidence-based medicine. So they're doing more than they should do. And it's going to start playing a major role in here. Now, which takes us to this. This is an example of what has happened with evidence-based medicine, what's happening right now. And many of you probably remember this. About in December of last year, the U.S. Preventive Services Task Force. Now, the U.S. Preventive Services Task Force is a group of primarily medical statisticians who understand all of this stuff I'm talking about much better than I do. And their job is to go through and see what is it that we do that actually helps prevent disease. They did that, for instance, with colonoscopy. Well, they looked at mammography screening. And before they did this, it was recommended that mammography screening begin at age 40. And their recommendation was it should not begin until age 50. They looked at the studies, they made the decisions, they looked at this at everything, and that was their final conclusion. It hit the fan when this came out in the news. I mean, I don't know if you remember this, but it was all over the news. They had people on all the talk shows. Everybody was talking about this. Within 24 hours, the Secretary of Health and Human Services got on the news and said, the government will not be following these recommendations. Don't worry, you can still have your mammograms. Even though this is where the basis was. And if we look at the arguments, I was watching this closely as it came along. There were several arguments. One of them is the scary one, which is probably going to be true, that this may eventually lead to a form of rationing. But as I looked at the arguments, they fell into these categories. One of them is it has somebody come on and say, I had my cancer diagnosed at age 45 and it saved my life. This was anecdotal empiric evidence. This is that one of the legs of that little stool that we had before. Empiric anecdotal evidence. Or they had someone come on and say, I've been doing oncology, gynecology for 50 years and I know you should start at 40. That's the authority. Or people say, well, obviously, the sooner you find cancer, the better. So all of these things that we talked about clear back at the very beginning, when we're talking about bleeding George Washington, were the arguments that were brought to the forefront when this task force came out. What I never heard on the news was anybody looking at the data. looking at the study. Say, does the study support that recommendation? So let's look at the data. This is what they used, among other things. But the main thing to look at here, cancer deaths averted per 1,000 women. We look here, annual screening starting at 40, 8.3. Annual screening starting at 50, 7.3. Their conclusion was that between the ages of 40 and 50, you had to screen an additional 1,000 women to prevent one death. Now, there's where the argument belongs. Is that enough to change the recommendation? Now, they said because doing all the screening causes women to be anxious, to have unnecessary biopsies, to have cancers removed that'll never kill them. They never mentioned money, but everybody knows that was in the background. Because of those things, they felt that this number was not enough to screen at that. Now, I personally, I don't think that many women really agree with that. They say, well, if my chances are 1 in 1,000 of being saved by a mammogram, I'm going to have the mammogram, even if it does lead to a biopsy I don't need. So the task force finally came out a couple months later and says, okay, we'll say, talk to your doctor, and if he says it's okay, it's okay. But the point of the whole thing is that when we had an episode here of evidence-based medicine by those criteria that we've been talking about, bump up against public opinion utilizing the arguments that we had back with George Washington, still won. So we have a long ways to go as far as evidence-based medicine is concerned before people will start looking and saying, let's not do all this emotional, anecdotal, my grandmother told me it was right stuff. Let's look at the data and see if it supports the conclusion. I personally don't think the data supported the conclusion. If this had been 1 in a million, if you had to screen 1 million women to save one, that would be true. But 1,000, that's pretty iffy to make such a major change in recommendations. The interesting thing about mammography, it just as a sidelight, is you just take a moment in your mind and think about what number would you put on the following question. How much has cancer deaths from breast cancer gone down because of mammography? What percentage decrease in cancer deaths from breast cancer have we seen because of widespread use of screening mammograms? Okay. You all got your number. The true number that everybody accepts is 15%. Now, I would bet that's a lot lower than what you think. Now, I'm a gastroenterologist. It turns out the number for colonoscopy is 60%. Colonoscopy has decreased cancer deaths from colon cancer by 60%. Really much better test, plus more people die of colon cancer than breast cancer. But a lot of publicity, a lot of stuff, and mammograms are great, but expectations are far exceed what reality is when you actually get down and start looking at the evidence. So I'm a big believer in utilizing evidence. But here's one of the dark sides that's going to come up, and this is going to happen. It's going to happen. We just passed the health care bill, and it had a lot of great things in it. Okay? But one of the things that is going to happen is that it's going to be extremely expensive. About 10 years from now, we're going to decide it's too expensive. We can't continue to do the way we're doing it. So we're going to have to figure out how to cut back, but we want to do it with some scientific basis. And the beginnings of that is now what's called comparative effectiveness research. We're going to they do this in Germany all the time now. The Germans can't understand why we don't do this now. If you have 2 treatments for the same disease and they differ in cost, let's see which one is the most effective and if it justifies that difference in cost and make our decisions about whether or not we're going to provide it. For instance, in my area, there's a drug called Prilosec, omeprazole. It helps with heartburn. It's just been generic. Generic omeprazole costs at Costco 40 cents a pill. Okay, now there's a newer one out. It's called Nexium. Had a little tweak in it, so it's the isomer, and it works maybe like 10% better. It costs $4 a pill. So the question is, should your insurance be required to give you Nexium for that 10% when it's 10 times as expensive? Those are the questions that comparative effectiveness research is designed to help us answer. Is this change worth it? And it'll come in cancer treatments. When Governor Levitt was here, he talked about the fact that if he was offered a cancer treatment for $250,000 that extended his life 1 year, he'd pay that. But as a society, we may eventually decide differently as we look at that comparative effectiveness, and that is already happening. And it's happening actually. And now, I don't want to give any idea that I think this is either a good or bad idea, because it's both. But let's take a look at Oregon. Oregon has decided that they're going to start using this. And so what Oregon has done is they said, under our plan, under the government, under our Medicaid plan, we have a certain amount of money. And so instead of just throwing that money out until it's gone, we're going to list everything using this research from the most cost-effective to the least cost-effective. For instance, routine childhood vaccinations are very cheap and very effective. That's at the top of the list. Those we're going to pay for. They're free. You get it. As you go down the list, there are other ones where it gets worse and worse. And finally we get down here to medical treatment for plantar fasciitis. Or you might put on there heart transplant for a 90-year-old. You know, these are things which are expensive but have very little benefit. Well, we're not going to pay for those at all. This is how much cost sharing means how much the patient's paying. That's off the list. So what they did now is they list everything down on this cost effectiveness research scale. Then they figure out how much money they've got. They go down and they draw a line. They say this is where we'll run out of money. If you're above the line, you get that treatment. If it's below the line, you don't get that treatment unless you pay for it. It's the bad word for that is rationing, but when people talk about this, Germany, Oregon, people think about it, over and over again they say we're going to have to get used to the rationing word. Hopefully the rationing will be based on some scientific evidence-based medicine. So when President Obama talks about we want to use evidence-based medicine to control costs, he's correct. That is what we're going to need to do. But the unspoken next sentence, which will come and hit us in about 10 years, is it will be utilized to ration healthcare. The fellow who wrote this particular article, I took this from, made the comment that when it comes down to healthcare, we need to paraphrase Abraham Lincoln. We can provide some of the people all of the healthcare, or all of the people some of the healthcare, but we cannot afford to give all of the people all of the healthcare. Cannot afford to pay $250,000 to extend somebody's life by 6 months, because we need to use that for childhood vaccinations where it will extend lives by decades. So that's the practical application of where we are. I'm well in the camp of scientific evidence-based stuff. I'm always looking for people who are using some of these other arguments we've talked about, either in medicine or out of medicine, and find that interesting. But I think that's all we have.
Some of you have to leave right now. Why don't you just go ahead and leave, and for the rest of you who can stay for a few minutes, we'd be happy to entertain some questions. Any questions for Dr. Trainer?
Oh, yeah, I'll look at that. Forgot my conclusions. We'll put it up there. Can you take the card? Oh, you can take the card if, okay, let me read my conclusions. The conclusions: association is not causation, personal experience is unreliable, and evidence-based medicine will play an increasing role in healthcare delivery. Okay, now you can take the card. Okay, questions?
I have a question. When you showed the decrease in deaths due to by having mammography,
Right.
and you had one death in 1,000, and you had 8.3 and 7.3. What are the error bars on those numbers?
Oh, well, that's interesting. Yeah, I was going to bring the study, and I should have done that, so I'll get it to you, because I didn't look at that.
Can you repeat his question?
Well, one of the things, I don't know if I've got is there a blackboard behind here?
No.
Okay. When you're looking at studies, one of the things that you have to look to is what's called the confidence interval. And that is, these numbers you look up here are the mean, but is the confidence interval, which means where do most of the cases lie, is it really close around there, or is it really big? And that tells you really how good you are. And that's what he's talking about. And to be honest with you, I don't remember the confidence interval, but I think these are big enough that it was small. I think it was small.
Beyond the 10.
Yeah, so it was.
Not like 1 or 2.
Right. I don't think there was any overlap in the confidence intervals between those two screening things. But any other questions? Okay. Thank you.
Sure.